call this meeting to order. Dr. Bates, get started.
Yes, sir. Thank you very much, Mr. Chair. We appreciate this opportunity to bring our partners to the table and talk about some good news, things happening at the health center, and also with our health care, health insurance, trust fund, and plans to move it forward. So I'm going to turn it over to Sarah and Mr. Hensley and the great team we have here.
Thank you. First, if I could take just a moment, in the back of the room is Derek Boyce and Ryan Summers. They're two of the partners of Helix. I know you've seen the Helix name, but I don't know if you've had the privilege of meeting their partner that are working with Rose and Care to bring the services. You guys for coming. And sitting next to them is Dr. Sanders, who's their CMO from Wisconsin. She's down here for a couple of days working with the team, and we're excited to have her with us and keep things moving forward.
How cold is it in Wisconsin right now?
Whose weather do you like more?
It's about 30 degrees.
Oh, you keep that up there.
Which do you prefer? Okay. Just making sure your head was clear.
Checking
know
her
what we're
mental
working with
status.
there.
A couple things, and then I'll turn it over to the Rosen team to present this quarter's update. Dr. Zoe Salgado started yesterday. She'll be working 4 days a week, Monday through Thursday from 7 a.m. to 5. So that gives us an extra 40 hours of MD level care. Dr. Perez continues to work his 3.5 days. So that gets us up pretty much fully staffed as we continue to expand, and Dr. Perez is able to go ahead and close out his private practice, and we will have some ability to then add hours. So between those, and we'll speak more on that, gets us a full complement of staff.
Are we confident, and I don't know if this is the right place for this, but I guess, are we confident that Dr. Perez is a good fit?
Yeah, thus far he's been doing
Okay.
well.
Yeah.
Okay.
You know,
I mean, I don't want a guy to close out his practice and we go, you know what, it's not working out.
well, he was closing out his practice.
He was wanting to, he had a desire to transition anyway.
Yeah, I know we
But-
talked about it
yeah,
earlier, but I just want to make sure we
yeah.
think he's a good fit.
I mean, the proof's in the pudding, but I mean, he was very successful with my previous employer, and that's
Okay.
where I found him and was able
Gotcha.
to connect with him. So, I mean, there'll be some patients love him and some that go, no, I think I'll move on to the next one, but that's why we've got 7 people sitting in the building now. So I'm excited about that. Number 2, I'm very, very excited that we have Deer Walk. You guys have been hearing about it, and quite a bit of our time today will be to introduce that to you, to show you some of the things that we're already starting to dig out of that data, and where we'll be spending our time and energy looking for those gaps in care, actually targeting both educational and outreach and treatment programs based upon what Deer Walk's now telling us. It's going to give us a lot of opportunities to find those cost containment opportunities, and you'll see some of the numbers that we now have because of Deer Walk that helps us be able to say that we truly now know where we should have been sending care to, where we should have been spending our time and money. It'll be pretty evident to you. With that, I'm going to turn it over to Ashley and his team.
Yeah, Kenneth, I think you're up on the
absolutely.
medical center side.
So on the medical center side, we're really excited about the things that we've accomplished to this point. I'm really excited to get to the Deer Walk and really, we've talked a lot about some of the data and some of the things that we've seen in the past, but it's here now, and we're going to be able to work together with Rick and his team to say, okay, these are the solutions that we need to bring to the table and move very quickly. So just going through the health center report, you're going to see that we have increased the utilization, but also you're going to see that the increase has not only been on the type of visits, but the unique individuals. And so on the very first page is just talking about the scheduled appointments, but then the total number of unique patients. Now, one other, I think it's on another slide. So those unique patients, we do have employees. Majority of it's going to be the employees anyways. And then also on the female, it's almost exactly the ratio of your female to male population. So these are just some basic utilization numbers. Next page just shows, okay, what has been our trend based on that specific time frames and specific days. And this helps us with mapping out, when are we going to be using providers, when are we going to staff up heavily, or when do we need to move providers into different schedules. And so as we continue on and we see trends, we'll be able to react to those trends accordingly. Next page is, again, the utilization by day of the week, just again by totals, and then the patient encounters. Now, these encounters here, you see 1,225. That's a 35% increase over the previous month. So you can see we are continuing to grow the number of encounters that are actually happening at the medical center.
And this gets us back up to the levels that we were experiencing with AH just prior to them leaving. So we're finally back to that capacity, hopefully with more results and more impact on the quality of care and the type of care that's being provided.
And you're going to see those numbers increase. These numbers do not include some of the drug screening that we were doing. I think we did like 120 of those drug screens during that period. And as we continue to ramp those up, not only the DOT drug screening, the pre-employment drug screening, that's going to all add into these numbers. So this total here of 1,655 does not include the drug screening, so it's actually better than that. We're trying to figure out how we can put that in there.
What do we save with each drug screening, dollar-wise? Is it a direct, like, if they go somewhere else, it's 35, if they come to us?
It's probably about a 40% savings to bring it in-house. I mean, I'd have to go down and set the numbers, but I mean, and more importantly, it's access. It's engaging those employees into the health center,
Right.
which there's really a direct value
It's an easy introduction.
for getting them into the health center for whatever reason. Because if they have a good experience there, then they're more likely to come back for other services.
That's a good idea.
So the only reason we delayed bringing that in, we just didn't have the capacity. And I couldn't afford to give up primary care slots for those other ancillary issues. Well, now that we're fully staffed, we're working things out, and we're incrementally bringing those back home.
I like it.
Yeah, so on those pre-employment drug screenings, we're doing them every Tuesdays and Thursdays, and we're talking between 15 and 30 individuals on those days. So it is a great introduction into the health center and the experience, and we'll capture them as quickly as possible, as long as they pass their pre-employment. So we did about 120 of those. On the DOT, we're going to be starting those in about a week or two. We just had to finalize some things between human resources and the teams, but we're going to be getting those DOT randoms.
We were going to start this week. I can say that now because we aren't really going to, but somebody declared it rodeo day, and none of the people
For the last
on the test are going to
50,
be
70 years.
That's somebody's called God, by the way.
I've heard it's a pretty sacred thing down there.
It is.
So the next
Don't you be
page,
messing with Rick. I've been on your team, Rick.
I'm
Don't
with you.
get me
I'm
off the
not-
team
I'm
now.
not complaining. Well, except that I have to work. I didn't get, they let me off work.
focus.
Get a pair of boots.
So on page 7, this is an area that we recognize as a concern, and we have re-implemented the policy that we are going to charge patients for those no-shows. This gives you a graphic and plus 584 visits that we could have used for somebody else. And so we spread the word. I know that Rick and his team sent it out to everybody. And we actually got some phone calls from patients saying, I didn't miss my appointment, but it was just a general notification that we are starting this, and we have to be firm on this. Because look at 584 patients. And this is one of the things that we have to fix quickly, because we have the patients who are saying, I can't get in at 8 o'clock. Well, if your coworker sitting next to you would have canceled that appointment, you would have that spot. 584, and you see some of these are repeat offenders.
Yeah.
We have to go after those individuals, and we thank you for giving us that policy. It's implemented. We're running with it already.
So they get one
Yeah,
warnings,
one
and then it's the second time.
But
it
look at
needs
that
to be
one.
like
390
excommunicado
people
from
no-showed
clinic.
one time. That's still a lot of visits that we could use somewhere else.
One person is
No-show means that nobody called it to say,
The chances are there was repeat no-show to PT, because we had a couple of them that, they had a whole book of PTs that they.
They didn't actually call and get an appointment 7 times and not show up. They got sent an appointment and just never came.
Yeah.
Okay.
let's think,
And you've had about 4,500 encounters,
Yeah.
but board,
so it's 10%.
isn't
Yeah.
there a reminder text that patients get
Yes.
where it gives them the option of just saying, cancel or confirm?
They do get texts, and they also get phone calls.
So these 390 didn't even do the cancel on that text?
They didn't do anything. I mean, as simple as calling us and just saying, I can't make my appointment.
So, yeah, unfortunately for some people, they don't pay attention to you until you get to their
Yeah, one
pocketbook.
time.
And for that minority, then we've started that process. Like Ken said, we sent out the notice that, hey, we are now reinstituting the policy that we have in place.
It's 24 hours, right?
Yeah.
Yeah.
And then the first round of letters of actual giving them notice that they have violated the policy, those go out this week. Every 2 weeks, we'll be sending out a new set of letters. And then.
What are we charging them, $5, Tim?
25.
25?
Yeah.
After
After the second one, yeah, first one's for free, just, a courtesy, and then second one's $25, the third one is $25 plus prohibited from making appointments for 6 months. 6 months.
Third one.
Third one.
Yeah, I can't remember the exact wording.
Well-
Next, page 8 is just breaking down, what could we have done with those no-shows? We do have schedules every day. We have X amount of spots that we try to use for same-day call-ins that we want to work them in. But if we can get these no-shows fixed, they'll give us better opportunities to see patients who call us that morning. Next page are just the medications. Again, the breakdown of what medications are coming out of the medical center internally, and we're constantly going to be looking at this, and it's going to ebb and flow as we analyze, is it an over-the-counter medication? Is it something that we need to carry? Or is it something that now is available for free somewhere else? I mean, we're going to constantly look at this because this is a cost to you. Any questions about meds? Azithromycin, are we starting?
Potassium. Potassium. Nothing.
Okay.
I had pot, I just was curious if we were giving out pot.
The next page is the most common that we write that goes out of the medical center. And so we're going to, again, evaluate this to see, do we bring it in-house? Is it cheaper to bring it in-house or to leave it in your network outside of the facility? So this is, again, going to be a running type of report. Any questions about external prescriptions?
I see a lot of these medicines on here, and I actually use the Flonase and whatnot. I mean, I buy all that stuff over the counter, and I get a prescription for it. So, what's the deal on? I see ibuprofen. I see all that you can buy the omeprazole and all the acid reflux medicines OTC now. So, I mean, why?
So, I mean, that's a really good question. That's actually something we're looking at. Let me give you an example really quickly. If you look on here, you'll see
I don't use them.
Like Prilosec. You heard about Prilosec as OTC. Well, Prilosec was a great prescription when it was there, and it had to be a prescription, right? The company came up and said, you know what, it's going over the counter because of patents. So the company took the Prilosec, changed one little isomer, and now they've got the purple pill, and now they can charge $186. So it's actually, we're going to be evaluating this, but it's actually good that you carry this on an OTC, because if not, the patient will say, I can't afford it. I'm going to go to my doctor and say, you know what, it's not working for me, and I have the purple pill, and now it just costs you $200. So we're going to look at all of those things, and we have to figure out, okay, how do we move those pieces around?
Aren't they violating the rights of that other purple pill?
No, it's the same company.
Oh, okay.
They did that on purpose. One little isomer, and now they make all this money.
The other thing
And I
too
know
is,
I'm on
when you have a prescription for something over the counter, Ricky? when
I'm
you-
listening, yes.
When you have a prescription for something over the counter, and you hold on to the prescription, you can submit that for your FSA.
Okay.
You can use that as long as your doctor prescribed that for you.
That's what I'm saying. I just see a lot of prescriptions in them.
Yeah, you just
No.
hold the prescription in your
But a lot
file.
of these were,
That's Claritin at the top.
Yes.
So you can buy
I
over
mean,
the counter.
because I take that
prescription.
seasonally, but we're prescribing it.
Correct. So this formulary, because we didn't have data coming from the previous provider, we just adopted that and added a lot of the things that we wanted. Now we're going through it and recognizing it, that it might make sense to take some things off, but that's exactly what Rick and our team are going to
yeah,
be doing.
we discussed that today. We're going to start, every 6 months, there's going to be a formulary review where we analyze what we're prescribing, what's coming out of the health center, and what opportunities are there to move that back to the marketplace or to over the counter. There's some of the over the counters, like you said, we're going to want to keep because it's not that expensive and it assures compliance. As we become more involved in workers' comp issues, we want to keep some items that would be over the counter that are kind of minor pain meds, because we want them to walk out the door with everything they have. But we're going to look at those, make sure we're not spending more money than we should, and that we're managing that. Or we may give the first round of it, but then after that, they're going to have to go to the marketplace for long-term care.
And that's an important point, because about 25 to 30% of Americans will never fill their first script. So if we can give it to them, that increases the probability they're going to take it and stay on it. So those are the kind of things that we're going to be managing to make sure that you're getting your best bang for your buck, because your Prilosec is probably, I think it's like $22 or something like that. But I'd rather you guys pay $22 versus $200 for the Nexium, when all it is a little shell game. Next page, on page 11, what this is just a survey that's done at the end of the visits to see, okay, if you didn't come to this health center, the school district. Oh, the clicker.
Oh, I'm sorry.
If you didn't come to the health center,
You're
where
all
would
right.
you have gone? And so we put together, this is what the individuals had said. If they didn't come to the health center, they'd go to urgent care, they'd go to another PCP, a specialist, or the emergency room. And then we used your data from Deer Walk to extrapolate, okay, what would it have cost you? And so this is the cost avoidance that you've achieved during the period of the time from October 1st to January 31st.
And the urgent care, convenient care, that's the ones that are popping up all over the place now.
Everywhere.
And that's the ones that we're really trying to, that we hope that our employees don't utilize. I guess less than an emergency room. Of course, if they have an emergency, something that's right there, I get it.
We're in the process of getting kind of a flyer that will tell you if this is the appropriate level of care, if you have XYZ, go to the health center during its hours, or go to a convenience care, because that's truly the cheapest option. If it's this, go to urgent care. If it's this, go to the emergency room. So we're going to start communicating that throughout the district, just to kind of start educating our workforce on what's the appropriate level of care and direction of care.
And where you really get hit by that, Ricky, is you get hit by the unit cost savings because it costs a lot more to go to the ER than it does urgent care. But it's the 66% chance of you getting admitted and them keeping you in there for a couple of
Gotcha.
days, running a bunch of tests.
They are
at a very
admission
high
centers,
rate.
aren't they?
Yeah, they are.
And there's actually
It's
in other
bad.
states,
You'll-
they're
I
being
know.
monitored because actually some of the hospital administrators have told their doctors, I don't care, you have to admit X amount of patients, and they're coming down on that. So our goal here is just to point out, where would they have gone if they didn't come to your health center? And yes, we're going to be evaluating, what are the right places. Urgent cares are popping up, the Centra Cares, the Florida hospitals, the HCAs with the Care Nows, they're all over the place. But there are other centers that are more advanced that we will be looking at together to see, hey, is this a place that we want to steer people, not only from the unit, but also from the quality perspective? Some of the things that we have done with our company.
And this cost avoidance is really a function of the decision the board made years ago to have a health center in the first place. It's not
Correct.
necessarily a function of who's running the health center for us, correct?
That's correct.
Right.
I think it's a function of both, because depending on who is running the facility, that person would have gone to the facility versus, another place. So I think it could be a function of both.
Well, yeah, I mean, the better run the facility is, the more people will come and utilize, so the cost avoidance will increase.
Yeah.
But fundamentally, this is really a function of saying, in theory, you might argue the word theory here, but in theory, you have $2.3 million of cost avoidance every year just by the pure fact that you guys have put this in place.
Absolutely.
So if this trend continues, this is a third of the year, we'll apply that times 3, then we avoided almost $7 million, and we spent, what, three and a half?
I was going to say that if the trend continues, it means that you need to invest in an east side and a west side facility.
Yes,
Poinciana keeps coming up in conversation.
daily.
I mean, you can do whatever you want.
Multiple times
Poinciana
daily.
St. Cloud probably be first on my list. No, I'm saying.
We're- We could co-launch them, just give me the
I'm
word.
giving you a hard
Just
time.
give me the word.
You guys make the assessment and do whatever you feel is best for the district.
So next page is after each encounter, the patient will actually receive a text message talking about how was your service, and they actually can fill in those comments, and it comes back to us. And so those are monitored, and we will respond appropriately. Some of the things that I've also heard, I've heard through grapevines, and actually my admin heard at a soccer game that it costs $60 to come to the health center. I want to make sure everybody understands it's free. Your school board is paying for it to come to the health center for free, not $60. I heard it twice. So I want to make sure, not only I saw it online, but then my admin at a soccer game heard it from one of her friends. So I want to make sure that's clear. So here you can see the number of actually surveys that have come back has actually increased over time.
What, if that's out there like that, why wouldn't we send an email to all our employees?
We have.
They
We've communicated. It takes 7 times to get to some of these people. I mean, it's just human nature. They don't listen.
And we heard the same thing about pediatrics, and we sent out, Rick and his team, we put together a little flyer of some of the things you were hearing, and just saying, we see pediatrics, it's zero cost share. I mean, those type of things so that we can get the patients to understand what's the truth and what's out there. It's free to come to your school district facility. The next page is some of the providers here, and then as Rick had indicated, Dr. Salgado started yesterday, so we're really excited to have her on board 4 days a week.
How long did you say is she there? Just for an hour a day?
4 days a week.
4 days
10
from
hours.
7 a.m. to 5 p.m. 4 days
Oh,
a week.
it's a long, all day.
Full day. Full
Okay,
day.
the other one's a half day.
Yeah, he's
Just when it goes to high.
he's there. The other doctor's there Monday morning from 7 to noon, Friday morning from 7 to noon, Wednesday from
I
noon to
misheard
7
something
p.m. So we now have an MD level provider on staff, on board,
Rick,
on
we're in the
duty,
wrong business.
all 5 days of the week.
Earlier, you asked a smart question. That one.
Then I said something really dumb.
On the next page,
But the next page may be able to help you.
yeah, so.
Mental health.
We can schedule an appointment for you, Ricky. So one of the things
Operators
as
are
we
standing by.
recognized, yes. One of the things that we recognized 2 weeks after we took over was, some of the type of visits that were actually coming to our providers, and our providers were spending a significant amount of time. Thank you guys for getting us the data. We put together the cost benefit, shot it up to Rick, and right up the chain of command. We have a mental health counselor who's there, and he's actually seen, I think it was 22 patients. And so we're continuing to see that ramp up. So I anticipate we're going to grow that piece and maybe some other opportunities related to mental health and psychiatric type of care.
Dennis,
Yes.
just a question. How do they access the EAP professional at the health center? Is that I need a mental health appointment? Is that somebody from the district office does a referral? No.
So it is, so what you had in a contract with CompPsych is you allow 15 hours of a provider being there, so they just call and schedule an appointment with that provider.
Okay.
And the nice thing is people sit in the lobby, you don't know if they're coming in for the blood work or
Right.
who they're gonna see, so it's, the confidentiality is kept there, but from what we've seen, it ramped up really quickly, because we had actually 17 patients on a wait list. And then we brought Terry in, and now it's running very well, and I'm very pleased with the kind of results that we're getting from him.
And I'm like, have we communicated that widespread?
We chose not to yet.
Okay.
Because we were trying to accommodate those that had a clinical need.
Right.
And then as we ramp up some hours and some staffing on the mental health standpoint, we will start getting that out a little more.
We're seeing so many referrals.
April's sharing it right now.
Yeah.
I'm messing.
We're getting so many referrals through the providers on site that it's really kind of creating its own
Okay.
energy. And again, as we continue to communicate our advancements.
I won't include it in my newsletter this month.
Okay.
Real
Maybe
quick,
next month.
while you're on an area of specialty, I spent some time, I don't know, a nutritionist or dietitian, whichever her title is.
Dietitian.
The fact that we have that there is a great asset. She's super passionate about her work, as you guys know. Getting more of our employees to understand the work that she's doing and knowing that a consultation with her would be really valuable to them in reducing diabetes and all these other things, as well as just creating overall health and well-being, is really key. That's why I don't remember which one of you guys set up the meeting. Maybe you did set up the meeting for me with her, just so I can kind of understand the work. That's really important work. As you guys know, I'm preaching to the choir, but that's that preventative piece that will really help everybody in this entire equation. So
The thing that
whatever we can do to increase awareness and access to that is great.
The thing that we've done since we transitioned is we are now teaming up. We have the Brittany twins, the dietitian and our wellness coordinator. They are now doing co-meetings and joint events and getting out into the community, working with our wellness champions at all the different sites. So that word's getting out. So we're making that move. As a matter of fact, I just approved ordering some cooking utensils so that they could actually go out and do some cooking classes around the district on healthy cooking. So
And we had a wellness fair here at the district office 2 weeks ago for our district office staff. It was outstanding. Both Brittany's were there. We had some other folks with healthy snacks and treats. Camp Gladiators were there. It was quite Blender Bike. The team did a great job, and it was very well received.
And as I always say, when we talk about diet and health, we make sure that everyone knows the healthy beef choice options that are available to them. Okay? We're not telling people not to eat red meat, not in Osceola County.
Noted. Remember, I grew up in Oklahoma City, like the third largest stockyards in the country.
Yep.
I'm with you, Cattleman's in Stockyard City, Oklahoma.
I mean, if I show up unannounced at one of these meetings and they start bashing red meat, I'm going to be really upset, and then I won't be laughing at this meeting.
I'll blame it on Kent.
Don't you run the largest tofu operation?
Okay.
Please.
And then the last
Moving on.
piece, about a week and a half ago, we started receiving medical records from the previous vendor, and so we're getting about 50 a day.
50?
Yes.
50, yeah.
And so we all know this was a work in progress, and it took us months. But we're finally there, and my understanding is there's...
Are we having to request the 50, are there 50 names behind it, or are they just starting at the top?
Just batches.
Just batches, 50 a day of batches.
Why is it now they're able to do this, but it was illegal for them to do it?
They were gonna be
You're
sued
welcome.
if they didn't.
Okay. Okay.
So, yes, we are getting 50 a day.
No, that's what I wanted to know. So,
And my understanding, there's about 1,300 consent forms that were sent. So hopefully we'll get all of that data. But you can see from the unique members that we have, that we've already seen, we've already surpassed that 1,300. So we'll just keep on trucking along.
great.
So in a month,
Here's the fun stuff.
get everybody.
Thank you, Ken.
Next workshop we have, we'll have everybody.
So we've got a lot of slides here, Ricky. I promise I'm gonna.
Oh, you're
get too
fine. I'll
granular
just
and
give
move
you
to
on
them.
that.
We're gonna talk about historical versus current costs. Y'all have seen that template. We're gonna talk about the high cost claimants, the savings regarding our and the quality regarding our initiatives. And next steps, the next initiatives that we want to roll out. But most of the focus, as Rick said earlier, will be on Deer Walk, and I think y'all will enjoy that. Mr. Rosen did want me to share a couple of things with you all. He sent Carol and me, and Carl went to a conference. There's a small movement around the country, we may have mentioned it, where employers just like you are kind of stepping out, and they're doing things that we've been doing at Rosen for about 28 years, and so everybody had a chance to kind of tell some stories. And there was a gentleman from that had 2 school districts out in Texas, and just talking about how everybody was a little bit reticent to do it at first. They were told no, seems too good to be true, that sort of thing. But their costs went down 40%. Their savings went up. Employees were not paying any deductibles, and so just kind of wanted you. There are others out there going through what you're going through. And he also wanted me to pass this out. We were both jointly in U.S. News and World Report, so you can pass that around to the left. You don't have to read it now. You don't even have to read it, but he was proud that we made it.
This is
into
about flex scheduling.
Need one copy.
Yeah. It just talks about Rosen Care in general, and
Mandatory
it mentions
dual
our
session.
relationship with you all. So if you'll
Make sure that anything in the future would just be comic strips and cartoons.
if you'll move to page 16, if you don't mind. I think that the key to notice there is if you go over to that upper left quadrant, that graph that's up, or the report that's up there. If you'll see 4 years of information. These numbers are probably going to change a little bit because Deer Walk is going to give us either confirmation that Cigna's numbers were right, or these might change in the next couple of months. But long story short, when you compare the current 3 months over on the far right, the current 3 months, it's $738 PEPM, and you compare that to the previous year, $811 PEPM. If that 738 continued, that's 3 months. If that 738 continued, that in itself is about 6.6 million in savings. Now listen, you don't know where it's going to go. We could have something crazy that we couldn't even control, some sort of cancer, tomorrow. But
A state legislature.
yeah.
Which is driving the mental health visits.
So anyway, overall, we're going to start seeing the numbers go down. We feel confident. Next page on 17. That's just a rolling 12 months. It's showing that your costs are exceeding funding by about 10%. But there's a nice slide on page 18 that shows since for this plan year, since we have had the medical center open, that your costs are about 5% below what is funded. Page 19 just basically shows your enrollment is pretty steady. You're in the mid 6,000s as far as your number of employees on the plan, and down below you peaks and valleys on what you're.
Which transfers into roughly 9,000, 9 to 10,000 covered.
Yeah. Yes, sir. Yeah.
That's the number we've been working on, right? That
Yeah.
9,700 or something like that.
Yeah.
And we're still kind of.
Right there.
But it's about 67 or something, and then 3,000 extras.
Yeah.
Correct.
Yep. Page 20 is your high dollar report. So last time, we had a couple of different high dollar reports last time. You all said, let's just focus on the ones that are $200,000 and over. So again, it's almost like that 80-20 rule. You got a few people driving a lot of the costs. So 30 folks, okay, on this list are driving about $11 million worth of your costs. So our hope for the future, and we're confident in that, is, we're going to have, we're going to get higher quality doctors, hopefully at a lesser price. We're going to be able to do a lot of prevention, as Tim was talking earlier, and we're going to be able to lower these costs.
So when I look at that very first one and I see medical surgery complications, and then that's something that the school district paid for, is there legal ramifications? Do you go after that? I mean, it's complications. Is it complications, or was it mistakes? I guess is the question.
It was a complicated.
Just complications.
Yeah, at least so like some of those could be where we go in and we think we're going to be doing a transplant, but their heart is backwards. I mean, those are just more
Gotcha.
complicated cases
Okay.
versus.
So we're not talking about it was a
something-
complication because there was some mistakes made or something like that. Okay.
As of right now, so we're still in the arrangement where we don't get much information regarding this because of the reporting that's.
Now,
going
we'll be
on, so-
changing, Rick.
But I think Mr. Smith is saying if any of our employees have been injured or otherwise the victim.
Call this when they-
I did not say that.
Starting to sound like a commercial.
You should. That one should be very familiar.
What is the time frame of the data on this? Is this the last 12 months or
It's
since?
12, rolling 12 months.
It's a rolling 12 months. And can you tell, what does the risk score column mean?
Here's it.
It's the risk score here.
Oh, yeah. So what that does is it just says, for these individuals compared to others, what was their level of risk at that point? So this individual with a 7 had only a 7% higher risk than the population, while this other guy of cardiac disorders had a higher risk of 46% over the average individual. So that person was high risk. Number 2, cardiac disorder.
Right.
Versus the guy who just had surgery, he was a lower risk.
Okay.
They're both
You're
ladies,
still
I think.
Female.
Oh,
But, yeah.
sorry. Yeah, female. I don't have my glasses.
It's all right.
Page 21. Carolyn, do you want to just kind of give us an overview of Deer Walk, and then Kenneth will get into some of the details?
I know we've talked about Deer Walk for a long time. It's been kind of this, maybe fictitious thing out there as far as what we're going to use it for. One is to get the data on where we're spending our money. We really want to find out how we can manage those people. Because if we can manage the members better, then that's how we really control the cost and help the members with their health. Also, the quality of care. Not every provider or facility or whatever are the same. So we want to make sure that the people are going to the right providers, the right facilities, and be able to identify those risk populations and give them the appropriate resources to help control that risk. So those are some of the things that Deer Walk can do. And it provides benchmarking for us as far as nationally, not just within a book of business within itself, and also comparing things to national benchmarks, things like Medicare. So that gives us how much are we paying compared to a benchmark compared to like Medicare. So that's what Deer Walk does. On page 22, a big cost of driver of medical costs today is drugs, therapeutic drugs specifically.
So on this one, it's just talking about, what are the different classes and then how much are we spending per day. The next slide is really where we want to focus on those different categories. So you guys had implemented your ElectRx program, which was valuable. And we're going to go into some of those numbers and see things. But here is opportunity. So look at your first three, your Humira, Humira-Pen, and Enbrel. Combined, you're looking at $1.2 million. Well, that's a part of your ElectRx program. And so we're going to continue to look at this data and find ways that we can migrate patients, because it's not only a win for the school district, it's a win for the patient because they're getting it for free. Also on this, you're going to see the Humalogs, you're going to see some diabetic medications, and those are the kind of things that we've got to continue to drive to ElectRx so you save money on your pharmacy. I think your pharmacy spend was about $14 million, something like that, on pharmacy side. So we have some room. Here's $1.2 million available. Same with the next page. The focus again is on the Trulicity, the Ozempics, because those are opportunities that we can shift to ElectRx, bring savings to the patient and to the program.
What are those for?
Trulicity is for the diabetics. It helps them with
It's diabetic.
Yeah. Yeah. It's new drugs, but they're very expensive. But if we can get it for 70% less, or 50 to 70%, we're going to do that.
But also, while we're on these pages, I'd like for you to look at the top on page 23. You'll see the category where it is. So there's right in the middle is the amount that we paid as for the whole, how much percent of the class is in that, and you have your allowed, usual, and customary, how much we paid. So you can see the variance there, how much is allowed versus how much we paid. And as we're going through that, and how you see the difference in invoices between ElectRx and what we're paying now, but also as we're going to market on our pharmacy vendor, we'll see some pretty heavy differences there.
And then the last column is paid. How much are you paying per day?
So is there a way? Is there a way that you drugs like this that you buy them and just store them at the medical center?
Yeah, not
You
these
can't do
kind.
that?
Not this.
Okay,
kind.
I don't know this business. That's why I'm
No,
asking.
but you're right.
Yeah.
You can buy in bulk, but if we have this opportunity with ElectRx,
Okay.
that's the route to go.
Because you're talking about getting people their prescription. You're talking about 25% of the people never filling them, and if we always talk diabetics. That's always the big one.
Mm-hmm.
And if we had them just on site, you
Put it
came
in
in.
their hands.
There you go.
Yeah.
Well,
I didn't know if you could
89
do that or not. You have to get it as a prescription from a doctor, single individual.
Well, and a lot of these are the items that we're now steering people towards the ElectRx.
Sure.
For that savings component. And having this data in more detail, we can now
Trend.
put a medical professional on outreach, as we've talked about doing. Now that we know where we need to direct, we can do those kind of targeted communications in the medical community.
$25?
Page 25, just focusing, here again, this is where your money was going,
Good Lord, have mercy.
as in providers. So just again, pointing that type of stuff out.
And remember,
Clarence.
and remember,
I'd already looked at it.
and remember that doesn't include the 3.6 million.
No, I got it.
Okay.
And as we evaluate these, we're going to make sure that we're sending your associates, your employees to the right place.
So if you're looking down, you'll see them, we were saying, why does there a certain doctor's name that's on there? Why are so many people going to one doctor? And Deer Walk noticed that it was that's really a provider, practice of doctors, it's an OBGYN practice.
Yeah, I looked that up.
So
You're sitting
it's
here, I'm
somehow
like,
Deer Walk pulled it under one name, but it is actually an entire practice.
Which one is that?
Like
Michael
Bartfield.
Bartfield.
That's like
Yeah.
about,
That's
yeah,
not,
OB.
Yeah.
there's like, I think, eight providers in that group. So So,
So
So
we-
he's delivering lots of our teachers' babies.
Lots of our teachers' meetings. Gotcha.
Yeah, and you see that you've got the C-sections, inductions, and those type of things.
Mhm.
Next, page 26. Here we're just talking. Okay, so here it's just talking about how we're going to be looking and stratifying risks. You're going to see that employees make up 72.4% of your membership, but the spouses are actually 65% have 65% higher risk than the average in the base, and then your employees are 17% risk. So when quickly looking at this, where should we go? We should be targeting the spouses, quickly looking at this. But as we gather more data, we're going to be able to figure out that.
I understand. I mean, look, I think we all know that there's, and folks make financial decisions for a lot of reasons, and totally get it.
Yep.
So, but in here, we put in green in the middle, the definition of what that, the risk score is, the Milliman's Mara score. And it tests the illness and disease burden and progression. So it's not on claims, it's saying, here's how much of a risk that person is. And what's the driver for a lot of it is to say, this person has such condition, but they're not getting treated for it. So therefore, the risk is going higher because it's going to have a tail end effect of it later. So they'll say it could be a higher score, but a low spend right now, but it could be a much higher spend later.
Yeah, like predictive analysis saying, hey, you are a diabetic, but we don't have any pharmacy claims on you, and then later on you're going to have some major problems because you're not getting the care you need now. And you're going to see some of that as we go through the Deer Walk.
So a lot of the things that you'll be seeing is comparing it to the benchmark. So in our previous reporting with Cigna was comparing it to its book of business. So I asked Cigna, I said, who are we comparing the benchmark to? And it's really comparing the Deer Walk book of business, which is all across the country. So it's all different groups. We're comparing it with 2 years of data and a little over 4 million members, and it's close to being 7 million members next year. And they're pulling it from the population factors. So they're factoring in the female population, the age of the population, et cetera. So it's adjusting accordingly. So here, this next slide, on slide 28, is going over our different plans. And we have what I call the base plan, the mid plan, the high plan. We have them called the local plus plan, the enhanced local plus plan, and the open access plan. So here we have so you can see a couple of them of how much the spend is for the 12 months, how much the PM, again this is per member per month, and then the overall risk score associated with that. When he pulled out, when I addressed the fact that there's this Teamsters thing there, apparently the Teamsters were on a different plan. Yeah, and so the data inside Cigna has those people separated out.
Yeah.
So it's kind of this anomaly thing. But one thing I do want to point out, under the high plan, when you see that 2.11 risk score, those are a few people that we have that have the blood disorders. So it's really kind of skewed because those claimants are very high claimants. So that's why those are in there, and I put the little asterisks there because it's really not, that whole population is a much higher. But what we learned is 1% of our members, so 90 people, spend an average of $190,000 and represent 35% of our total spend. So if we take $1 there, and we draw a line through a third of it, that's 1% of our population spends that. Then of these, 30 members spent over $200,000. 52% of the members were also at the top 5% the prior year. The next 2 to 5%, 358 people, their average was $45,000 and represent 33% of the overall spend. The bottom 50% of members, so almost 4,500 people, average only $83 per year.
Wow.
So that last line is half the people aren't even touching the plan. But 1% of the people are spending a third of it.
Is this typical? Sorry, Mr. Washington.
So to me, of course, that sounds insane, but how do we benchmark that? Meaning, what is the comparison to
Yes,
other
that
industry?
was my question.
Because on the surface, I go nuts, right?
Yeah.
But there's got to be a breakdown around that to say, hey, look, that's actually a national trend or an industry trend or a regional. I mean,
It's pretty common for 10% of your spend, 10% of your employees to make up 73% of your spend. We see it across all industries. That's pretty normal. It's really, doesn't fluctuate. I mean, I guess you could get into a real heavy blue collar group, might be a little higher, but that's what we want to see. Ken, is that what
Yeah.
you see?
I mean, some of the next pages are going to talk about where that spend is going, and then it is benchmarked. But on this piece with the Teamsters and those type.
But next month, we could just show another dollar, what the benchmark.
Well, but, I mean, look, if it's like, to Mr. Weishar's point, if it's standard across the industry, then it doesn't concern me as much as like if you say, "Wow, across the industry, there's nothing like this," then I say, "Whoa, what do we got going on here?"
Yeah, yeah, and
Well,
that's what Deer Walk will do. They
Yeah.
will look for anything atypical and go, "Oh, whoa."
It's part of the rationale of insurance.
Yes.
You've got a bunch of people paying car insurance. I mean, it's the obvious one.
And you know,
There's a lot of
that-
people hoping never to use it.
That one of those people in that bottom number, the 50%, one of those people is going to get cancer or something, or have a heart attack or something, and then that's the whole point of insurance. I mean, I get that part of it, but it does
The
seem a little
interesting
wild.
part would be of that 50%. What's their risk score for that
Yeah.
population? Because they might be on.
One of them's going to have a surgery complication. Yeah.
But more importantly,
But
the
they
more that
could be
we can
using
do to
100%
emphasize
out of the
wellness
medical center
to keep those
and
people
using
well.
all their prescription drugs from the medical center, and they wouldn't have $1 being spent.
Ricky, the key is turning the data into actual intelligence, which
Yep,
we're trying
sure.
to do here, which I don't think we've always been able to do in the past.
No, not over the last year or two. We've had these conversations ad nauseum. So, but here we are.
But this is also so. First of all, I like the data. By the way, this is the important type of stuff that I think we want to unpack and understand. Then we want to compare it so we can understand how to really wrap our heads around it, and then we want to take action to it and say, okay, now that we know that this is the bucket that is costing us the most money, which in truth is also becomes part of the narrative to the employee base to say, number one, understand that what you're really doing is you're having a collective sharing, and that you guys collectively care for the whole, and there's a subset of the whole that is the most expensive, which drives our costs.
Yep.
So understand that is the underlying piece, right? Insurance 101. But then from an internal perspective, we start breaking that down and saying, okay, if this is where 35% of our spend is, what do we do and what can we put in place exactly to start to mitigate those, get nutritionists, dietitian, wellness, prescription, all of these variables that need to be isolated to say, now how do we drive down those costs and increase wellness?
By the way, Mr. Thacker and I had, and Ms. Soto was there as well several times, our teacher meetings that we did, we explained this at every single one because a lot of folks just don't understand how it all works. And so we had this conversation at every single one and talked about we insure each other. They just thought Cigna was maybe the evil person. And Cigna doesn't have anything to do with this. It's all about we insure each other.
And it came from people on the right-hand side of that dollar bill and the left-hand side.
Yep, that's true.
That I don't ever use it. Why do I have to pay all this money to
Yeah.
the person
That says, I've got a health problem and why am I having to spend so much money?
This is another reason, though, why, what we would refer to as like a high deductible health plan or what's the terminology I'm looking for the not
Health savings
HSA,
account.
but hey, all of those variables are so important. I'm convinced that if America understood in truth how this really worked, more and more people would say, I'll take a high deductible health plan because I'm not really utilizing the health services available to me, and instead I want to keep saving that money and keep it for myself, or lower the overall amount that in our case the school board's having to pump into the system so that instead it can go into salaries and benefits and other things. It's really about people understanding how these things really work and how they don't work, and the idea that insurance is supposed to be exactly that. It's not supposed to be something you use just because you have a sniffle and a cough. It's supposed to be something you use for insurance, that major issue that comes up that you otherwise couldn't afford to mitigate or handle on your own.
Right.
And done properly, like you said, as long as people understand that, it would work. But traditionally, those plans have worked that people avoid care, and that Milliman score will go higher and higher and higher because they avoid it. They don't want to spend, they don't have anything extra in that bank account for the HSA because they're buying milk for their family. And so they don't go to the doctor because they can't.
And that's
afford
what's
it
happened
anymore.
over the past
And that's what's
10
happening.
to
So
12
that
years
risk
is the
score will
cost
go
have went
worse
up.
and worse and worse.
Sure.
And that's what we've done to our country with those types of plans because they people have avoided the care.
So 30 to 35% of Americans are delaying care because of
Yep. The cost.
the cost.
Mhm.
You know, I can't afford my deductible plus my coinsurance. So I'm going to have belly pain. It will go away. And so all of a sudden, that belly pain that we should have just taken out their appendix and cost us 10 grand, 13 grand, now becomes an appendicitis. Now it becomes ruptured. Now we have sepsis, and now you are paying 60 to 100,000. That's the delay in care that we're talking about.
Yeah,
Yeah.
and the
No,
whole
I
key and
understand.
the reason that we're going through the exercises we are is that the costs wouldn't be what they are
Yes.
if people understood how the system really worked and how to be smart consumers around healthcare. The cost would go down because the market drivers would demand it, and then
Yes.
people would be able to consume it at a far easier rate, and everything starts to work itself out. So I mean,
Correct.
it's almost that thing that you delay care and then you end up creating the enemy that you hate, right?
Right.
Because,
Exactly.
I mean,
Well said.
yeah.
You just said page 29.
Yeah.
So the other
We're
thing
good.
that we're doing, assuming that all things were the same and last year just repeated itself this year, we're also going to work on the agreements that we have with our providers in the area. So we're when we're out to market and our strategies for what we're going to pay to our providers and facilities may be different next year. So assuming that the medical situations all happen the same, with our strategies, they will go down because you will have better contracts next year.
Let me just ask you a question in line with that. We had a Dr. Betfield or somebody who was the
Yes.
OB doc. When we start looking at these, are we going to go in and look and say, we've got a lot of people going to this person, we need to talk to them first?
Absolutely.
Do some
Because
quality metric work around it too.
That's
Make sure
important.
the C-section rate's not 50% or in line with the national average.
No, I'm fine with going to them and saying, this is what
But
we
we
need
want
to
to make
pay.
sure he's a good doctor.
Right,
Yeah.
but, but it's important that if we've got, big groups using, or lots of numbers of people using the same people, we need to at least give them a really good shot.
Yeah, exactly. Because then you really have the opportunity. I'll go to you with, hey, here's what we've been using. Here's your spend. Hey, you have good quality. Let's work together.
Correct.
If not, take that out of your line item.
Right.
We're going somewhere else.
Tim, to follow up on your question, price equals cost times utilization. And no matter, you can employ 5,000 nutritionists at the health center, but if you don't bring the cost of care down, it'll never change. So some of the metrics we're all working on is to address the cost of care with the utilization component. But if we get the cost down first, we then can work on that. That's the hardest part of this whole equation. You have a shattered humorous is $198,000 and you end up paying $100,000 for something that costs $7,000. That's a problem, and that's been happening for a long time.
Yep.
So you were exactly right on page 29. Here we're talking about really the cost that you've been spending. So days per thousand looks at, how for your population, how many days are they actually spending in the hospital. But if you look here, the average cost for the inpatient stay is $8,849. That's 58% above benchmark. So that's exactly what you were talking about. This gives us an opportunity to say, okay, it's above benchmark. Where are they going? What facilities?
Why are we paying more?
Why are we paying more? Is it more complications? Is it infection? What is that? So at least now we know we're 58% above benchmark.
And that's benchmarking against a similar population as ours,
Correct.
which would be the 75%
Correct.
female, 25% male.
Correct.
And then same with the emergency room. Look, your average cost for the ER is $4,200 versus the benchmark of $2,269.
Wow.
So we need to dive into that, look at
Yes.
other opportunities, just like you were talking about urgent care or some of those freestanding ERs that we can partner with. And you see they're being built all over the place over here. So we can take a look at that and address those numbers.
So I guess my question, and I've asked this privately and I'm going to ask it publicly now. I don't know how long it's been 8,800 or 58% above the benchmark, but why wasn't that being addressed
There was no economic incentive to address it under the agreements you had in existence.
They
Okay.
didn't have Ashley.
We weren't at the table.
There was,
No, I get it, and I guess I knew the answer to the question already, but I just, it seems, it's troubling and it's saddening that
Frustrating.
and frustrating, all of those things, going through all the 5 stages of emotion.
Clarence had to leave the room.
Man down.
But I haven't got to acceptance yet, because it's still, these numbers really upset me, because it seems like we've got some things that could have easily been touched on over the past 3, 4, 5 years as we've navigated this, that just were never presented or never brought up by the folks we had working on our behalf, and so that is frustrating.
As far as the ER goes, so ER utilization is higher, so 13% higher than the benchmark, and resulted in admission 66% of the time versus 44% of the time.
So we go there more, we get admitted more, and then we spend twice as much when we're there.
That's right.
Bingo.
We can't do that.
They refer back to page 25.
They used to remember frequent flyers.
Yeah.
You can really study those.
Correct.
That's
yeah.
the next page.
So on this next page there, you're going to be seeing the different types. Is it minor? Is it lower acuity? And a lot of these could have been shifted somewhere else, to your urgent care facilities or to primary care or to home care. There's other opportunities. And then, but the life-threatening, that was pretty high off the charts. We need to dive a little bit deeper and try and figure out what do they mean by life-threatening, and we can try and figure that out. What was it? Gunshot wounds? Was it
Appendicitis. So
Yeah.
you avoided that stomach ache for so long. A lot of appendicitis can be controlled with antibiotics. Now, some.
Yeah.
But so you could have been giving a dose of antibiotics versus having to have emergency surgery now.
And then take a look at the bottom right-hand corner. 2 ER visits or more, and then 6 or more ER visits. 23 members went to the emergency room 6 times or more.
And is that in a year? Yes.
That's-
Rolling 12 months.
Yeah.
And with the data, you can click down each one of these, the ones that have the HIPAA protection, you can literally see who they are. And it might be as simple as diabetic that isn't doing the test strips and taking their medication.
I guess
Okay,
that's.
now we
yeah.
can't see who they are,
No.
but can you? That was going to be my next question as a medical professional.
We can drive down and drill down to that. Yes, we can get it from Deer Walk, and
We all
Into
have
the
HIPAA
medical center.
agreements with
Correct.
you guys on that.
and so then we'd be able to figure out,
So-
okay, who is this driver?
Yeah, how do
Six times.
you take the 23 people and just go sit down with them and try to have a medical evaluation happen? I mean, is that,
That's part of it. We
I mean,
got
can you guys do that?
Can you
absolutely.
call those 23 people and say, let's get you in here, let's talk
Yeah,
about
let's,
what's
let's
going
talk
on.
about what's
We
going
wanna
on.
help
Exactly,
you."
that's where I was
Yes.
headed.
That's where we talked
And
about.
your boss is never going to know.
That's where we talked about bringing on a care coordinator that would be looking at these gaps in care and would be a medical professional that could do that outreach.
Right, that's what we need.
Independent of us
Right.
completely, but within that health community.
I would say, and maybe it could be the example you just brought up, I'm sure some of it is, but sometimes if these folks just felt like they had somebody, a medical professional to talk to.
But the other piece is,
yeah.
I think, number one, obviously, the cost is much more significant than getting regular care. But number two, think about the lost productivity. Because somebody who's feeling so bad that they need to go to the ER 6 times in the course of a year cannot be productive at work. This is somebody who
They
needs
mean to
help,
take care
they
of
need
the,
support.
seriously, the mental health and counseling.
It might be.
Yeah,
might
it could
part
be.
of that.
You have a lot of presenteeism issues after exactly what Dr.
Yep.
Lee said.
But we'll have a program called a Crucialist program
Wow.
where, not right now, but in the future, where when someone's getting ready to go to the emergency room, if they don't want there to be any costs for them, all they have to do, like on their way, they can push the little Crucialist button, and then a certified ER doc will be talking to them. And if that ER doc
There you go.
says, you know what, you don't really need to be going there, hopefully that person will heed their advice. Or that emergency room doc may go, yep, you need to go to the emergency room, but not that one. You need to go to this one. And then we'll be glued to them throughout the whole process. So
And that's right.
we'll fix it.
I don't think I've told you, great example of this. I burnt my hand really, really, really bad a few years ago. Really bad.
Wasn't
And
that
you
bad,
guys
but he
remember
whined
this.
a lot.
Oh, yeah.
I didn't whine at all. I didn't whine at all. They didn't even know about it, but really bad. But the
Got a
night
big
that the
settlement
night
and
that I
everything.
burned it, I happened to have a personal relationship with my family doctor. I called him. and I said, hey, I'm going to send you some pictures, whatever, tell me what I need to do. Do I go to the ER? I mean, I'm in crazy pain. Do I go to the ER? What do I do? We talk about it. He looks at it. He says, you're okay. If you can make it through the night, come and see me in the morning. It's Friday night, Saturday morning. So I go and see him. Fine, open the wound, bandage it up, healing. You remember this, I think, as well, because we talked about it. That's it. What you just described is the key. Had I not known, I probably would have gone to the ER.
Yep.
I mean,
Most
my
people
hand
would.
was blown up, and
Why wouldn't
skin
you?
was
Maybe the hospital
melting.
does with a skin transplant.
Exactly. So that is so
Skin
key.
graft.
The amount of money that saved the school district just in that one instance of being able to know what do I do and what don't I do was vital.
Yeah, absolutely. And it's not only about steering them to the right ERs, it's also a home care component or just a phone call, we're going to call in a prescription. So there's several components to it, and that's something that we're actively working on and hopefully we'll have completed.
So when we say right ER, I guess I wanted to stop there for just a second. I'm not asking you to name names or anything like that, but if you say live in St. Cloud, for example, and essentially there's one emergency room in St. Cloud. I mean, are we going to tell people, hey, which I mean, I'm okay if it's it's different, whatever. Are we talking about telling people to drive over to Celebration or drive to Orlando, or how does all that
Matter
work?
of life threatening. So are you bleeding from the head and you're in a car
I guess
accident?
that's
It's different than
And who makes those
someone's
determinations and
driving
how
you
do we
because you
do
broke your
that?
That's where
hand.
we get that crucialist involved. It's a board-certified ER doctor who's
Okay.
saying,
I thought he just
but there
wanted
are
to go
cases
with that
where you call 911, 911's going to take you to the closest ER, that's
Exactly.
their policy.
Or trauma.
But we're going to get you out of there if it's not the right place as quickly as possible.
Yeah, so even if you do go to that one, that's not the best one, but it's so emergent, you need to go there. That doc is going to be so glued to you that when you're in there and they're telling you, I think you need to stay for 4 days, well, please talk to my doc. Yeah.
Okay.
Next is, the types of visits that were done to the emergency room. You see, we highlighted several of them. The cardiac disorders, 30.53 versus the 19.89 from the benchmarking. And there's your associated spend per visit for that specific disorder. Diabetes also, bless you, almost twice the benchmark. And again, it's drilling down to what's going on with those diabetics, why are they going to the emergency room, to try and figure out how can we prevent that in the future. Is it they didn't have their medicine? Did they not know how to use their insulin? Did they run out of the insulin? And if they did run out of the insulin or they couldn't afford it, we've got the ElectRx program that's got it, and now it's available. We've got to continue to drill down on these populations. Musculoskeletal disorders, you see that it's higher than the benchmark. Again, we've got our IMC and our PT, our physical therapists over at the health center. So those are the type of things that we're trying to draw back into the health center and keep out of your emergency room, unless it's they got injured during a soccer game or something like that. Then obviously there's things that we have to do at the emergency room versus the health center.
I'm trying to see if there's anything that we're lower. Dental conditions are lower.
Again, chronic conditions. This is the prevalence. How many individuals have that type of diagnosis? And you see, hypertension is 1,395 individuals.
That means we have 1,395.
In our population?
Yes,
Wow.
Okay.
yes, sir. And then on the diabetes, 658 versus the 517 benchmark.
So the benchmark is what the other 7 million people in Deer Walk experience, or
I
whatever.
think they compare it.
Like,
Is it
and
to the
they're-
all of
they're
4 million, or are they
aggregating it
comparing us? to
They're adjusting for
populations
your
like ours?
each gender factor.
Okay.
And so again, this is just to show, how many individuals are we starting with from a prevalence standpoint?
Metabolic disorders is
Like, obesity and insulin
thyroid.
resistance.
That's the diabetes, right? Or is that somewhere? No, it's down there lower. Headed that way.
Pre-diabetics, those type of individuals. And even obesity, obesity.
Should then that number is going to be higher than the diabetic number? I guess it is.
Well, pre-diabetics. So there are individuals we haven't even identified yet,
Gotcha.
really, from
All
a
right.
center standpoint.
So we're higher in almost every single category.
Except for lower back pain.
No,
Except
low
for
back
lower
pain, you're
back
okay.
That's because I haven't been to the clinic yet.
Yeah, we'll get a lot more back pain.
Osteoarthritis.
Yeah, osteoarthritis, I mean, that could lead to total knee replacements, hip replacements, but also in the coronary artery disease, take a look at that, 216. And that could lead to bypasses, and that could be $50,000-$60,000 or death.
What an upbeat conversation.
I know. But with the coronary artery, even with coronary artery disease, we're starting to see it now in earlier. 20,
Dr.
30,
Pace better have like 40 more 5Ks, I reckon.
I run one every Saturday morning. You're happy to join me.
Yeah.
Good for you.
Right down the road. Me and the cows.
Moving on. Yeah. Number 33, please.
In her boots.
I bring my mule out.
33 of so many. So here on these next pages, we were just breaking down a little bit more of the chronic care conditions, and we can go through it, but we have 47 slides. But here, the interesting part is members did outperform benchmark in compliance to gaps in care with 85% getting the A1C. So they're getting their A1Cs done, but the rest of the reports are saying that they're not controlled. So it's great that they're getting the test done,
Yeah.
but the point is to get it controlled, and that's what we've been talking about. You've got all these diabetics, they're getting A1Cs done, but nothing's being done about it. And that's where we're now able to recognize.
A1C push
I
last
would
year.
tell you that's because that was a huge point of
We did a
emphasis
push
for us a
last
year ago. That's probably much better in the last 12 months than it was in the
Yeah.
previous
Oh,
12
yeah,
months.
So
absolutely.
they're getting it tested, but doing nothing about
Right,
it.
the actions, the next phase.
It's a
of it.
start.
It's a start,
Yeah,
correct.
but then the barriers, the cost barriers start kicking in.
Right.
The meds and the
Okay.
But our average cost for this condition, including the comorbidities, is about $16,000.
Yeah, so it's either, now it's aware, but either unwilling or unable.
Yeah. Yeah, they might have not been able to afford the test strips or the Lancets or the insulin, and now you guys are bringing it all to them, so there's no excuse. You've removed the barrier to the access of care. Next is coronary artery disease. We talked a little bit about that, but you can see that the per member per year of $43,000 is significant. Again, they're getting their
Yeah, I don't like
A1Cs
talking
checked.
about that one either.
But see that, however, only 51% are actually taking cholesterol-lowering medication. And we have some of the other data that shows on the statins, they're not taking those statins. Why? They might not have been able to afford it.
Maybe they were just young and they didn't feel like it was time yet.
Yeah, damn it.
You'll be happy to know that my cholesterol is down to regular level now.
Yay, there you go.
Maybe when I was 30, I didn't want to take stinking medicine every day. I didn't feel like I should be. I was that guy.
Again, on the cholesterol patients, you can see that they're getting their test done, but only 40% of them are actually taking their medications. And then that leads to coronary artery disease. Coronary artery disease leads to bypass. Bypass leads to $60,000. You can see the progression.
I won the weight loss challenge, so I'm good.
There you go. So, your atorvastatin that could cost, a couple of dollars that, some individuals couldn't afford to get, now you're getting all those medications for them. Hypertensive, we talked about the hypertensives, but one of the things that we've got to dive a little bit more into
Frank, this is
is,
very depressing.
yes, we've identified who's got high blood pressure, but are they controlled? That piece we need to dive a little bit more into. We know if they're diabetic and have high blood pressure, we know if they're controlled or not. But specifically the 1,395, we need to dive a little bit more into that. So we'll figure that piece out.
How much are we able to incentivize all of these people in these spaces to be hyper engaged in, no, I shouldn't use hyper in this context, but be engaged in the preventative care that needs to take place? And I guess it's really a question for you guys or HR. I mean, like,
with the point system and all that.
Legal as much as you want.
You can, there's about a 30% differential, Tim, that you could make a differential unless you charge someone that's not compliant or what it is.
You can do that then.
You have some room.
Obviously, first and foremost, their overall health and well-being, right? These are serious issues that we and they all need to take seriously. But then the other part, just think, how do we incentivize behavior in a way that says, look, you have to deal with this, and
Mr. Weisler,
It's part of the culture.
humans are interesting beings,
Oh, no.
If they see,
What time is
in
it
general, we're running on 1.0 software, they're not going to have if it's going to be something that is horrible, but it's not really like happening next week,
Yep.
it's hard to get people motivated. However, I think that educational campaigns do work. I mean, they really do, in the public health setting. And if it's really, if it's presented in a very convincing way that, hey, if you do not do these things, you're gonna have a very, very horrible time, pain and misery, that does work.
Almost like if we said, I'm just on, like we said, every one of these people, we're gonna give you $1,000 to get this in order. You know what I mean? Like, it sounds insane,
Well, I
but
think
the
that-
savings would.
It really goes back to the culture piece. And
Definitely not.
changing the culture. So, every month I do a wellness letter. We've got the nutritionist now. We're advocating exercise. We have 3,000 people signed up for our 5K, which is also going to be a wellness fair. So we just have to continue to take advantage of the opportunity to emphasize wellness, taking care of yourself, the health centers, access opportunities, where they can go to get reduced care. It takes all of those things coming together. But it's not like you flip a switch.
I get it, and all those things are good. We need to continue. I just know also what happens is that everybody always thinks the message is for somebody else, right? When Pam's sitting there telling me things that aren't happening right, I swear she's not talking about me as her husband. She's got to be talking about somebody else. The message is for me, right? So I mean, that's the thing is we've got to be able to have those direct conversations. I remember when we were together at Rosencare. I know when we were together at Rosencare, we talked about the personal attention to the individual needs of the patient/employee and making sure they know we're here to help. We want to understand. When we see that there's 1,395 members, we want to be talking to those people regularly and say, come in, visit with us, let us help you.
And that's where we need that care
that's what
specialist.
they had-
Somebody
this-
providing that
yeah.
direct outreach from a medical provider standpoint that you and I can't as an employer.
Right.
It's
And
people
what-
helping
We have an
people.
employee?
That's what the
We
whole
will-
thing has been.
What we will be looking to do is, as
Yes.
a team, we'll be looking to those
No
educational
medal, no
opportunities.
finish.
And the word that we quit using, and we started using the word incentive, could also be called de-incentivize. We've got to have the carrot and the stick, and the pluses and the minuses. If we want people to quit smoking, then we need to look at a smoking penalty. I mean, and I think our team needs to put those together piece by piece as we continue to move forward. And it's a marathon, not a sprint. This is going to take us 3 years to really turn the ship. But I think we're moving in the right direction. We've got the right tools now. We have the right team, and we're developing that strategy, and we're going to start implementing it piece by piece by piece by piece. And we'll be looking back 3 years from now going, wow, that was incredible. Because I think we've got the right tools now.
Sorry. So we're going to skip a couple of these chronic care conditions, the cancers, the lower back pain. You can read that. But on page 37, that's what we're talking about. If you see the D14, hemoglobin A1C less than 8%, the goal is to get them controlled. Because if you're not controlled, you have things that are like eye problems, diabetic retinopathy. You have kidney problems. That could lead to dialysis. And you guys are going to spend a lot of money if we have any kind of kidney disease or if we have to amputate. So that number there that's telling us 623 people don't have their diabetes in control, but we don't know why. Now we've got the tools. We've got the tools to figure out who they are, and we have this resources as ElectRx to get them the medications they need, plus the health center to get the A1Cs and get everything that they need available. That's the key to this. And then on the colorectal screening, colon cancer, I mean, it's preventable. You can find it. But what we've recognized here is we have a gap. We have a gap of individuals that we need to get to. But what we've also noticed, if you turn to the next page, is we're spending too much on the colonoscopies. You guys are spending way too much. So this data has given us an idea that, hey, we need to go ahead and do a direct contract of some sort at an outpatient center because your members are spending $400 of their own money for a colonoscopy. Do you think that might be delaying care? Possibly. But if we can do a direct contract like what we've done at the Rosen, it increases your probability of them getting it done and it removes the barriers, we can fix this number.
What type of number are we talking about? So putting in place a strategy just outlined. What does it save us? What does it save the employee? Just a rough estimate.
I would like to get rid of we haven't even talked about this, but get rid of the employee share and get us south of $1,000 for a double endoscopy, colonoscopy. And we'll work on that piece, with a provider and with Rick.
$1,000 for a colonoscopy.
Right.
That's just
$3,000
is what we're paying.
That Well, it's no more insane than a whole lot of the other stuff we talked about.
Yeah.
No, I understand.
It's the same amount of insanity.
There's color guard and there's all the other things you can do. There's certain colors you could do. On the box that you could take home.
I paid $800.
Not for
when I walked
everybody,
in.
but.
Probably the thing.
And then again, here, that same page on the utilization, here we're talking about, where the individual's going and then what kind of spend we're spending. And these are
Turn around.
opportunities
It's
for
too
us.
easy to
And Ashley's gonna
nip
talk
it in the
about
bud,
the
as they say.
savings.
We're almost done.
Yeah, almost done. We'll be on time.
You're good?
Page 40, you've heard us talk about the green imaging, right?
Yeah.
The initiative. So for October and November of 19, 147 CT scans were done. This is about 20% higher than the benchmark. The average cost is $2,600. Your cost is $2,600 versus the national benchmark at half of that amount. Who is the most expensive? Shocker. Who is the least expensive? Osceola Regional, and our cost that we're providing you if they go to the right place is 65% less than your lowest cost one. It's 85% less than Advent Health. So, long story short, if all of your CT scans were done through green imaging, you'd save about $2 million a year. Just CT scans.
But for our average, the employees paid $829 and the school trust paid $1,798. So when we put in the green imaging solution, their range, depending on the test, is between $300 and $450 per test, and the employees pay nothing for that.
Is
So it's
green
totally
imaging a
win-win.
place or a group of
It's
places?
it's a country that contracts with other imaging centers. Dr. Dickerson is an incredible person who I had the pleasure of meeting her last week. She calls it Travelocity for imaging. So she contracts with quality imaging centers where they have vacancy and have downtime. She's sending people to those facilities
It's
at a
been phenomenal.
fraction of the
1,000
cost.
centers, under 1,200.
Well, and going through all this makes it better. I mean, the big deal is where it says employees pay zero.
Yeah.
And that's what the big win is here.
Yeah.
I mean, it's a win-win-win, but, it's
Yeah.
great to say.
District saving money, people are getting healthier,
Yep.
and the employees not
And they
paying
get the care
anything.
they need.
And it's important because in the very beginning when we started,
Look
we
at
were
page
wanting,
43 to see the numbers so far. It'll blow you away.
Mr. Booth, it's important that we recognize that in the very beginning, as we were seeing patients and we were wanting CTs and ultrasounds, patients couldn't go get them done. They couldn't afford it. And so now we've got the tools for our providers and our team to really care for our patients.
No, that's great.
So there's how much we've saved in.
Yeah, $150,000. And again, this is not linear, right? This is gonna take off. The more education we do, the more outreach we do. This is gonna take off. What I like seeing is that in this bottom left-hand corner where it says number of images, you can kind of see the exponential. 49 in November, doubled in December, doubled in January. We want to keep on seeing that trend.
And we just sent out the postcard about green imaging. So hopefully February and March we'll even see continued increases.
And this, on page 43, this green tally, is just savings from CT scans and MRIs. We had the CT and scans and MRI data from Deer Walk, so we just filtered those invoices out, how many CT scans and MRIs did we have done, and that's how we calculated your savings there. But again, not only the school trust, but also the employees saving money. So total, 100, and that's just 3 months, and that's really not even talking about it that much.
So that doesn't include
Does not include ultrasound, it's just CT and MRI.
because we've ordered.
Yeah.
So when somebody goes somewhere besides green imaging,
Deductible.
but that's my point. I think we brought this up. We're talking about Walgreens and CVS. Don't we get to a point we go, okay, we are paying this for that, and anything above that is your responsibility as the employee. Like, are you allowed? You're not allowed to do that, or how does all that
Would
Not
work?
have
the
to be
current
after-
arrangement, no.
Not in our current contract.
But you can build that out.
I mean,
If you wanted
we
to.
had this discussion. It costs at the grocery store. Pick one. It costs $4 for this prescription. It costs $40 at CVS. you paid 4 here and you paid 4 there, but we had to cover the rest at the school district. And guess what? We is not me and Mr. Weisshire, Mr. Thacker. We is all the employees.
Yeah.
Your other employees. So to complain about I can't go to Walgreens or CVS, you had to just pay for that person to go there.
Yep.
And so I think that's the story that we have to tell. But and I'm not trying to jump on them, but when do we get to a point on the imaging thing to say, okay, you can go to Advent, I don't want to say any names, you can go to X hospital and get the imaging done. But because you can get it done through green imaging at
$1,000.
We're only going to pay this.
So we're only going to pay
$1,000.
X number of dollars, and then anything that costs more, because we know you could go to any of these 400 other places and get it done for less.
Yeah.
You're going to pay the difference.
Depending on what we do for the renewal, depending on the flexibility of doing that in the future.
That's where
Or
we-
find your plan design. That's a big discussion where you can do a lot of those.
I understand.
But it's commonsensical, and it can be done if y'all will allow it to be done.
And Ricky, to your point with the drugs, when we get to that or whenever it happens in the future, you can set up different preferred and non-preferred networks like you do for medical.
I mean, look, we're to the point where we have to make, just looking at the legislative numbers and all these things, you're to the point where you say, look, if you're going to make choices, and you bring this up all the time, if you're going to make healthcare choices that cost everybody else a lot of money, the burden then over that is going to be on you. And not on all the rest of the people that get covered. Because basically what's happening when you decide to go to somewhere else besides a green imaging, it's costing all the rest of the people, your coworkers, it's costing them money out of their pocket.
And it would depend on what happens in the future. If you have an SDOC logo on your ID card, that's SDOC insured, but, employer-billed healthcare. And that's the big difference right now. People see the insurance companies and they don't always know, like y'all.
Then I'm
said.
sure somebody's going to tell me that there's some reason why that won't work and it's not a good idea, but.
Yeah, you'll hear that from some folks.
And that's fine. I mean, maybe there's some valid points. I can get that, but,
No, generally what you're saying works. Yeah.
okay.
And that's part of the.
I'm not trying to be mean, I'm just trying to be fiscally responsible, trying to make the right
It's the
decision.
reality of where we have to be.
Accountability.
And
Shut
it's a lot of the data we're looking at right now includes those possibilities.
If you go to page 44, we're almost done. This is our Elect RX initiative, and you'll see that about between 40 and 43 people have gone in the months of November and December. We've saved $45,000 in 2 months. So again, don't multiply that times 6 and try to come up with an annual number, because that's going to be way low. This thing's
It's
going to
ramping
really,
up there.
it's going to start
It's
ramping up
growing.
big time.
In January, we had 63 scripts filled with about a $27,000 savings just for that one.
And
Just for January. So
yeah.
In February, I haven't seen numbers for February yet, but I know that they're still moving in the right direction.
And our savings for the ones that were purchased in November were 52% less, and in December it was 57% less.
The 40 members was direct from the card that was sent out. I mean, we sent the card out, got 40 people.
Well,
Grapevine,
so I
people
think that,
talking.
Okay.
And
It's
also the
people-
health center.
The health
Yeah, a lot of
center,
that originally was from the health
and
center.
one person
Okay.
had it done, and then they're spreading it. The word
So we
about the
believe there'll be
spread.
even a bigger bump?
Yes.
I mean,
Yes.
when we put the postcard out during the Christmas break.
Okay, it was Christmas break, not
then
November. All right.
January jumped to 63
Okay.
with about a $27,000 savings.
I'll go back to what I said last time. Postcards great, it works some. We've got to we've got to use video, we've got to use social. There's a whole different way to communicate with people, and I think the 40 some odd is great.
Have you seen the Facebook ad?
It's on Facebook.
Yeah, we've got it on Facebook.
Good.
April.
Spread it.
but also calling people up and saying,
on
hey,
Facebook.
did you know?
Yeah.
April's posting it right now.
And it's not on MySpace yet, but we're.
MySpace.
Is it on your TikTok?
That's Mr.
account?
Thacker's. That's Mr. Thacker's Facebook or social media presence.
Did
MySpace.
you get it in your AOL Messenger client?
Oh, yeah, that's old. That's old.
Yeah, you'll see a lot. On 45, you'll see the drugs that are being prescribed. Is a lot of them that you saw on the chronic condition page. And we want those peer groups, those people, to talk to each other and saying, hey, I got it. Now, again, a couple months ago when we first started the medical center, we had employees that were coming to us in tears. You know, we had one employee that was suicidal because she couldn't get her medication and she couldn't afford it. So, again, they're saving money, but a lot of people couldn't even, they're not saving money because they weren't spending it before because they couldn't afford it at all.
Real
So-
quick, April, my recommendation, if that's already out on the school district page, share it. You've got some people that are following you, they're employees. Share it direct from the page over and say, save money, save money, save money. I mean, that is like, that's the stuff that y'all could be kicking out. Okay. That's the stuff we got to get out to make sure people know how to save money and utilize these benefits.
Thank you.
And the,
Okay,
and
good,
the wellness champions have been pushing it real hard for us as well, as the Brittany twins have been out and our team has been out. So it's permeating. It's just, you know, a lot of it's cyclical. 90-day meds. We're still in the middle of the first 90 days of the year. It'll just continue to grow.
Yeah, these are the money savers that people need to see and take advantage of.
And we can do those now, and we're doing those now, even with the current system. So that's why we're doing it.
And it's easy to make that sell when somebody comes to the clinic and gets prescribed one of these.
Correct.
That's an easy.
Correct.
As far as other, we may call each of these impact initiatives because it makes a great impact on everybody. The opioid clinic management program is in place. So that's, we have a organization that we work with, and they are analyzing the data, and they're working with those providers and identifying who the providers that are prescribing our members inappropriately, and working with them to get them back to track on that.
That number was 721, if I remember correctly. It's almost
I believe
burned in
you're
my
right.
memory
Yeah.
because when you told me that, I was blown away.
And that's potential, so it's not.
Potential, I understand, but still,
That,
potential, just to be identified as that.
Yeah.
We provided him updated data, so the numbers dropped some.
Okay.
600 and
But
some.
I'm going to just tell you, I was going to bring this up if it wasn't here because it made such an impact on me that day. Because it seems like the state, I thought the state, and under Governor Rick Scott had a big initiative and got rid of the pill mill. That was a big thing about 8 or 10 years ago. Got rid of those pills, put some people in jail.
Yeah.
I mean, so are there still people out there brazen enough today, doctors, to prescribe these things not in the manner that they are? Are they skirting around something or what? I mean, you guys know more than me.
The members have become pretty crafty at how to.
It's the more the members getting around.
Because they're addicted.
Yeah,
And you
sure.
become addicted pretty fast. I think the statistic that we just
good
heard the
folks.
other day
No, I understand.
is when you have your wisdom teeth out, was it 5% of the population will end up getting hooked on opioids
Wow.
from wisdom teeth being out? Which is part of our rite of
Is
passage.
hydrocodone, is that an opioid?
Yes.
Okay, so, no, I'm just saying, lucky for me, it makes me nauseous, so.
On-
Me
on
too,
the
I
other
get terrible.
hand, Something else that we're pointing out right now
Yeah, and they give the 30-day supply, that's right.
correct, is, we have a pharmacy partner here in town, Eric Larson. who
Prescription
owns a
Unlimited,
pharmacy.
St.
Yes. He just got a box installed at his pharmacy looks like a mailbox, it has a bunch of locks on it and stuff, where people can bring their old prescriptions that they don't need anymore. So they're not sitting in your cabinet at home, potentially someone going in your medicine cabinet.
So let me
and
ask
taking
you
them.
this. If we, say we have a potential employee who's getting crafty, as you said, and they have went to 5 different doctors, and those doctors probably aren't looking, so they don't know that they went to this one and got it, went to that. Is there a management system that we have in place that can say when they go to that pharmacy with that prescription, the pharmacy says no?
But they're supposed to from the state. Each provider is supposed to go in and see, you just got it from Dr. X.
And they are a lot better than that. The
Yeah.
providers are a lot better
Okay.
at complying with
Because
that
they're very-
in the past,
But-
since Scott.
But this tool that you guys approved last month, this is our target, our ability to target that and try to either eliminate inappropriate care or redirect to other options of care.
Well, and then there's a plan in place besides that too, because of the addiction. We don't want people then driving to the wrong side of town and buying heroin, right?
And
Like
starting
it's
heroin.
happening. We want to try to get them through the addiction process and those kind of things. Correct? Okay. Good.
The other 2 high-impact initiatives on the agenda tonight, the FLAX contract, which is the pulmonology direct contract, which will give us a direct access to sleep studies, which are critical for our bus drivers and our DOT requirements. That's on your agenda tonight. Others will be able to use it as well. It's another cost savings for both the plan and the member to break that barrier down. And then the mammography bus contract is on your agenda tonight as well. So hopefully we'll have that out in the field in the next few weeks.
Chair and Soto, I think that's it from the team. We really appreciate our partners from Proventure and Rosencare, certainly
Thank you.
everybody
Yep.
who's a part of the team, and Mr. Hensley and Sarah for really driving this work. Just a couple of quick reminders before we close, sir. We do have our CTE special recognition. It's at CTE month in February in Florida. So at 5 o'clock, there'll be exhibits out in the lobby area, as well as some food in the orange room or whatever they call it back there. And then we have executive session following the board meeting for the purposes of bargaining discussions.
Very well.
We must be giving away
Anything
some
else?
awards to
Just a
some
good
kids
job,
or something
guys.
tonight, too.
Thank you.
Thank
Okay.
you. Thank you.
All right, so we adjourn.
Or am I hearing things?
We got something going on. We got a bunch of stuff going on.
Yeah, you got to roll.